Good evening, everyone. Once again, you are welcome to Doctor Presentation. Today, I will be the anchor and presenter of this today event. And the topic is keynotes in case mismanagement, government hospitals in perspective. And our theme is insight into clinical practice versus reality. I'm Dr. Basaru Lateef, MD, General Practitioner. The aim of this narrative review is to shed light on the opportunities provided by patient-centered care and technology use as a means to improve and reshape healthcare problems resulting from case mismanagement. To do this, I will cover the following scope: introduction, definition, key factors, take-home points and solutions, conclusion, and endnotes. Amidst the background of numerous challenges confronting the healthcare sector, such as rising costs, as we all know, the cost for medical care is quite at the high rise and expensive. Even though in the rural area where things are quite cheap and people don't have the financial capability to treat, at least for a malaria in the hospital, will cost you 10 to 20,000, and that is almost equivalent to minimum wage. Another important issue is the chronic disease upsurge due to the way we live, what we eat, and what we do, and the lot of junks that we do consume, and quite stressful nature that we suffer. Due to this, there are all such based on statistics of chronic disease like osteoarthritis, diabetes, and hypertension, as you all know. More importantly, is issues related to patient safety too. It is against this backdrop that presentation seeks to provide solution to these challenges using pertinent emerging models. Case mismanagement could occur due to several factors. However, in this presentation, we shall limit discussion to keynote factors affecting mild to moderate disease. And what are these? Mild to moderate disease are diseases following the natural course of evolution without complication or severity, such as uncomplicated malaria. What am I trying to say on this slide? Initially, in the evolution and progress of any disease, for example, malaria, which is quite common in our area, patients tend to present with uncomplicated common symptoms, headache, fever, vomiting, and by getting the right assistance from medical care, they don't have to suffer from complications from this. For example, severe malaria, anemia, which is one of the major killers in children below 5 years of age, cerebral malaria, and liver failure, and most importantly, what we call Waterhouse syndrome, black water syndrome precisely, which tend to affect people that are non-resident in malaria endemic zone by having kidney failure and severe anemia. This is a picture showing a doctor in a intensive care unit to see quite how demanding it is and skillful to save someone's life. By way of definition, it is quite often noted that patients suffering from chronic conditions in our society today are inappropriately managed due to so many factors, and some of which, in an environment or in a community or in a country, the ratio is supposed to be a doctor to 600 patients. That is, a doctor taking care of 600 patients. However, in our society, based on the last statistics, we're having a doctor to 5,000 patient overload. And in such circumstances, I doubt if doctor could perform in the optimum. So eventually, most of the patients that cannot get best managed, they end up being managed by quackeries or quack doctors or quack nurses. And this will lead to complications, which eventually bring us to this topic, which is case mismanagement. Of course, such cases are meant to be mismanaged because it's difficult for a doctor to handle 5,000 patients properly. The next point is lack of basic and adequate medical equipment. Most of the time, patients go from one hospital to the other hospital without being properly diagnosed. And of course, without diagnosis, a good diagnosis, you can never have an appropriate treatment to better resolve a patient. Quack doctors infiltrating all the environment. The Medical Dental Council of Nigeria have not been putting so much pressure or allowing their weights to control how quack doctors create or proliferate hospitals, clinics around the country, which of course, a lot of cases on newspaper, people have lost their life due to quack doctor operating, carry out CS or minor surgery, appendectomy on them in the theater. We have self-medication. In our environment, people tend not to value the money accrued to the quality of services or healthcare delivery. Hence, they believe anytime they have fever or run any symptoms, what the next thing to do is to go to the chemist and get medication, or talk to their neighbor which have a similar illness and get medication. Of course, by virtue of definition, this is self-medication, which is quite wrong. In fact, it is a known factor that even a doctor, you are not allowed to write prescription for yourself in an environment which are quite enshrined in their constitution. Such doctor might be fined or indicted, let alone patients now take a drug. Then work time overload. The WHO standard is for a doctor, a physician, or health caregiver to work within a minimum of 8 to 10 hours. But in an environment, you see a doctor working 3 places, keep call duty in this place. By the time he's working on the infirmary, he's facing another environment. Doctor keep call for continuous 1 week. Doctor keep call, and the second they continue doing. The mental capability cannot be subjected for longer period to have an optimal management or idea of to manage mistake without making a mistake. So the time overload is a key factor in contributing to case mismanagement, as we have rightly said in this presentation. The proliferation of unqualified staff consulting and dispensing drug in chemists. You go to a chemist, you want to buy a drug as a doctor, of course, without the person recognizing you, he start asking you your symptoms and giving you all sorts of medications. There's a case in Kaduna in 2016 or 17, if I'm not wrong, would be elucidated based on the scope of what the author intend to discuss. This brings me to the key factors challenging and confronting leading to case mismanagement in our environment. The inadequacy of medical doctors, followed by WHO standard. A guy took his sister to a chemist to get a consultation. Unfortunately, among the drug that was written for this girl was Septrin. And this girl reacted to Septrin. Of course, he went back to the same quack doctor that the patient is reacting. Oh, say, fine, the disease are showing out, so hard more drug for him. Eventually, this girl presented with Stevens-Johnson syndrome. We are all doctors who know what is Stevens-Johnson syndrome. It's like a severe cutaneous manifestation of drug reaction, presented as severe skin burn, and eventually, patient deteriorated and lost his life as if he was set on fire. These are the challenges we have in the environment, and such case, patient lost his life. A picture showing a physician working in a special center. As you can see, they are wearing their asthma suits, but most of the time, we don't have this equipment due to lack of fund or lack of resources. And eventually, people tend to run for their life and not doing the best thing for the patient. Of course, this is another factor that will eventually lead to case mismanagement when doctors are not well equipped. Of course, another slide that is quite important, the trauma beam on the picture, is showing a traditional birth attendants. There are a lot of traditional birth attendants which are instrumental to having a complication during delivery. Fine, we have a large statistics on numerous of people delivering safely in the traditional birth attendants, and they tend to believe in them. Whereby people say people tend to die in the government hospital. The fact they don't know, they fail to realize that majority of the cases like CPD, cephalopevic disproportion, or failure to progress in labor that will lead to complication are cases that were mismanaged by these traditional birth attendants because they are not midwife, they are not ORG consultants. And by the time they are presenting to hospital, they are coming with complications, fetal distress, meconium aspiration, eclampsia, you can name it all. Eventually, such case may lead to maternal mortality. The patient might die from it. However, the government will find a way to make sure these traditional birth attendants can little be trained to recognize cases that might lead to complication, which they will refer, because you cannot eventually rule out or stop the proliferation of these traditional birth attendants. Of course, one of the reasons that contributes to case mismanagement are from them, even though the government and authority are doing their best to train these people and make sure they are aware of complications from maternal birth attendance. If you go on internet or Google, Nigeria is one of the top 10 leading cases of maternal mortality death ratio. Factors contributing are from people like this. This is a fantastic picture showing a theater room, a standard state-of-the-art theater room. Of course, quite unfortunate in government hospital, even in teaching hospital, people use torchlight to operate. And such cases, patient may end up losing his life from hemorrhage or bleeding. And yeah, another beam of light can be thrown to factors also contributing to case mismanagement, which are quite unique and pristine. It's non-orthodox medical diagnostic equipment. For most of us that do travel once in a while, we've seen by going through the airport, people will put up equipment and say, please, okay, come and do total screening of your body. They will screen you from head to toe. Imagine somebody screening you, just passing some rays or beam over your body and telling you he's making a diagnosis of kidney failure, heart failure, without having a basic electrolyte and urea creatinine to evaluate the glomerular filtration of such patients. So and people tend to consult and seek for their consultation because this is quite deceptive. It has no value. And patients from such places can end up being mismanaged. Quite unfortunate, authorities are not doing or controlling such thing. It's quite unfortunate. One-time fake miracle from religious leader. Of course, I'm not pointing the accusing finger in this case. However, from experience, when I was doing our job in the Federal Medical Center, I've seen people coming from certain churches with advanced stage of HIV, which is AIDS stage, WHO stage 4. These are people that were registered in the hospital, diagnosed in the hospital. Unfortunately, they were being deceived, cajoled, to believing that there's one miracle water that will cure you. And most of the time, the pastor tell them that you should stop taking your drug, that you are healed. Quite unfortunately, as I said earlier, patients come in the severe cases. By the time they come, they have all the opportunistic infections you can imagine, being pneumocystis carinii, pulmonary tuberculosis, toxoplasmosis gondii, encephalopathy, and paralysis. Severe anemia, patient is cachectic. Eventually, we tend to lose suspicion because where do you find some little statistic number can be revived or resuscitated or saved, but quite unfortunately, large number end up losing their life or end up being palliative patients. Consultation via social media. Of course, I'm not talking about telemedicine. Especially if somebody has a doctor friend, you just saying, what's up, doctor? I'm having a day. What can I take? Doctor, I'm having back pain. What can I take? These are cases that may end up contributing to patients because in the medicine outline or fundamental of managing a patient, which are instruments to the vanguard of progress in clinical history, is first of all is taking an history, examine your patient, have a look, physical examination. This contributes to the precise diagnosis and management of such patients. Doctors-patient ratio, I've earlier said down that WHO recommend 1 to 600. In our environment, we have 1 to 5,000 doctors. A picture showing impending strike, of course, is quite common, or most of the time we do see in government hospital, state hospital, doctors going on strike to the fact that they are being owed incentive and salary for close to 7 months, even a year. Sometimes areas are not being paid. As you all know, the UN article rightly stated that health is fundamental human rights and a basic need and necessity, which need to be continuum and quite enshrined in constitution of serious countries. We cannot jeopardize the services of healthcare delivery. Hence, they need to be taken care of, not to be pushed to the extreme of having to strike or go on industrial action before being paid their incentives. As you can see, the other allowance of Nigerian doctors compared to 5 African countries from the slide, the pictures show an obvious statistics. This is statistics from ICIR as at 2019. Nigerian doctor at the least even being paid below $5 or below $10 precisely, where the comparatively Liberia pay as far as $825, followed by Sierra Leone and thirdly Ghana. And even the fourth country, which is Congo, Republic earn as far as $250, and we Nigeria earn less than $10. What is the take-home point? First of all, we need to create awareness of what is actually going on in the environment, because these are quite interesting things going on. Case mismanagement are not precisely due to lack of knowledge or skill by a physician, but that the factors that are confronting, challenging healthcare delivery. So creating awareness, people get to know what to do. Application of telemedicine, which of course, what is in vogue, the pandemic in 2019, COVID-19, has actually turned the tune of how people are being managed or how we react. People are of now very comfortable doing a lot of things online, and which is also the direction, the paradigm shift of medical practice is going to. A lot of countries are applying online medicine. Modification of pull and push effect. What is pull and pull effect? Pull and pull effects are the factors responsible or instrumental to brain drain. They are factors that pull you from your country, and they are also factors that push you away from your country. Of course, to get a greener pasture, the advanced world, which is federal, doctors or physicians or healthcare givers are quite remunerated in a large sum of money. This is enticing. The push effects are the environment that the doctors are working. The doctors not being paid for over 6 months, going on strike, training and being obstructed. These are factors that push the doctor away. So by ameliorating and modification this push and push effects, creating a very state-of-the-art technology, well-equipped hospital, we encourage doctor to stay. Giving back to the society, people like us that have the opportunity to be trained abroad, we can also assist by contributing our quota, either coming down to do medical rhapsody, operate people, give free healthcare consultation, just like what Dokota Health Foundation is doing through Dokota, its mother domain. State-of-the-art technology. Of course, there's nobody that does not fancy the advancement of technology. As at 2019, statistic giving shows that about 7.7 billion people make use of second and third generation assets. This is a massive proliferation of technology. Hence, we can harness this opportunity by giving consultation online to people at just a flick of finger click. Mitigating solution. What are the ways to solve this challenge? Confronting, leading, militating the caregiving environment, thereby leading to case mismanagement. Again, this disturbing background, there have been some reassuring prospects giving up, which have provided opportunities for the healthcare sectors to make reforms. Firstly, in the face of myriad of challenges contributing to case mismanagement, the Institute of Medicine suggested an approach for improvement and cross the quality casing. What is the first line of our solution? The first beam of light to be thrown in these challenges is the paradigm shift. And what does paradigm shift entail? Enhanced telemedicine and patient-centered healthcare, giving good incentive to emulate the push and push effect of brain drain, improve doctor-patient ratio. Employment does give scholarship to doctors to improve the number of doctor-patient ratio, so as to achieve the optimum WHO standard of 1 to 600. We've mentioned about the mitigating solution, and one of the things we emphasize on is the paradigm shift. And among these paradigm shifts, the beam factor here, which a lot of people, based on review and statistics from Institute of Medicine, they've advocated for patient-centered care. According to WHO, which actually advocated for people-centered care as a broad term to include patients at every level of healthcare system, and define this as a care that is focused and organized around the health needs, expectation of people and community rather than disease. Let me bring out a point here. During the 70s, early 70s or Hippocratic period, we talk about pattern care from the physician, or physician partner care. What do I mean by partner care or partner orientation? Of course, from the word partner, that's a parental father. You see a patient, look, you have a fibroma and you are bleeding. If you don't operate, you are going to die. And I think I'm going to take you to theater. You must operate. You have a malaria. I need to place you on admission, give you drip, regardless of whether they have something to do. But however, from statistic review, people or researchers, authorities are advocating for patient-centered care to be more focused on one of the factors that is germane and have generated a lot of contributions from authorities and focuses. What does it entail? According to Parker Institute of Medicine, there are 8 dimensions of patient-centered care outlined by Parker Institute, which include, first, response for patients, value, preferences, and express need. The patient tell you, Dr. Luke, where I am, I don't think I need to undergo surgery. I have a business. I have a business to, or a one reason or the other best known to me for not to undergo surgery. You have to consider listening to the patient and oblige the patient and give him informative consent or educative consent by having to allow him to understand the consequences of what he's saying, the solution, the benefit from such procedure you tend to do, and the likelihood of the progress if the patient denied the operation or the procedure. Another point is coordination and integration of care by involving the patient. Information, communication, and education, which also fall under informed consent. Physical comfort. A palliative patient needs to be given enough painkiller to make him feel well and satisfied. Emotional support, alleviation of fear and anxiety, involvement of families and friends, transition and continuity, access to care, which can be augmented or enhanced by robust telemedicine. Now, under the paradigm shift, we talk about the patient-centered care. Now, let's make use of the advancement in technology. There are 7 ways where the healthcare can benefit, or the 7 healthcare problems that can benefit from the innovative use of technology application. The first one is when you have no remote access to healthcare. What is the solution? People need to invest in healthcare, mobile and web, so that people from this far region have not having access to good road to travel down to hospital can access medical care through online. Likewise, the use of telemedicine and what example Dokota Health Foundation is doing. We talk about virtual consultation or online consultation. Existing silo in the healthcare world. We can create social networking, just like what we are doing, apps for healthcare. We have Medicare, we have up-to-date for professionals across the globe to access information and exchange experiences. Issue with Medicare and Medicaid reimbursement, non-payment of salary. Invest in Medicare and medical EHR system. Wastefulness and unoptimized supply and management. Of course, here we talk about LIFO and FILO. First in, last out. Last in, first out. Of course, with the use of data management system that automatically oversee this inventory, we can know which product is first in and which one is to be first out or last in to be first out. The system keep updating you gradually, maybe a week basis or monthly basis or fortnightly based on what your consumables are or their shelf life precisely, which is the terminology for knowing when to stock and unstock products. Managing the massive volume of patient-related data, what do we do? Make use of the cloud storage and data analytic capability. Is efficiency and errors in data sharing. Go for blockchain. A blockchain is being used in cryptocurrency. It is a kind of system being attached to outputs of what other systems offer. So thereby, at any point in time, you make input to an information on the web, it's being verified by the first user. So no other person can reuse such information, kind of double information. It's not like you register a patient in Kano and such patient was an HIV patient or any chronic disease. Just for him not to seek advice, he traveled down to Lagos to seek another physician or healthcare. With the use of blockchain, you can relate data that this patient was first initially registered in a hospital as Kano. So hence, we avoid insufficiencies and errors in data sharing with the use of blockchain. That's what blockchain kind of offer. Lack of online pharmaceutical store. You might get a prescription in Lagos and it's not available, or you get a prescription in Enugu, it's not available in Enugu. With use of online prescription, you can slot your prescription and place your order from Lagos and you get it delivered to your doorstep. That's one of the solutions the technology can offer us through the use of your mobile phone at the click of your finger. Setting up prescription based on online medical stores. This brings me to conclusion, with the aforementioned factors that are responsible for inappropriate management of cases in our environment are due to the fact that most patients do not manifest with complication initially. However, they keep moving around from quack doctor, from chemistry, unrecognized diagnostic and non-orthodox diagnostic equipment, and taking all sorts of drugs. And most of people still believe in herbal medicine. And by the time they present to hospital, they are poorly managed, and this case gets worse or present with organ failure, liver, kidney, whatsoever. And that is when they seek for appropriate management at the referral centers. Unfortunately, some cases end up as terminal cases with palliative management. That brings to the head of the presentation. Thank you very much for your rapt attention.